Thank you very much. Good morning, all. My name is Dr. Daggash Bishara. I am from Nigeria, and I'm a resident of Nigeria Field Epidemiology and Laboratory Training Program. My presentation is on evaluation of measles surveillance system in Borno, Northeast Nigeria, 2013 to 2016. Measles is a vaccine-preventable disease of childhood caused by measles virus, which is an RNA virus. It is highly contagious and has a high case fatality rate of 1 to 10%. In Africa, it accounts for 13 million cases annually with 650,000 deaths. Sub-Saharan Africa has the highest morbidity and mortality due to measles, and outbreaks in Nigeria occur during the dry season. The dry season in Nigeria, especially in the north where measles is more endemic, runs between November, December to May. But then the peak of the outbreaks are seen between March, April, May. Measles surveillance in Nigeria is fully integrated into the IDSR, which is the Integrated Disease Surveillance and Response. Measles surveillance is case-based. It became fully functional in 2006, and it leverages on the acute flaccid paralysis surveillance system that had already been in existence. It involves immediate case reporting and investigating any suspected case of measles using standard case definitions. This is a flow chart that describes the flow of information for measles surveillance in Nigeria. Information is gathered from the health facility and transmitted to the local government area. And from the local government area, it is transmitted to the states. And from the states, the information goes to the Federal Ministry of Health. And the Federal Ministry of Health is responsible for coordinating the overall surveillance activities. The thick arrows that point downwards show the flow of information from the health facility down to the Ministry of Health, whereas the thin arrows that point upwards show the feedback that goes back from the Federal Ministry of Health up to the health facility. At the health facility level, the health facility focal person is responsible for conducting active case search. He detects cases and informs the disease surveillance and notification officer. He also sends weekly reports, including 0 reports, to the local government. At the local government area, the disease surveillance and notification officer assigns EPID numbers to those cases that have been identified. He is also responsible for completing case investigation forms. He collects specimens for laboratory analysis. He also investigates, analyzes, and responds to the cases. At the state level, they are responsible for monitoring surveillance performance, and they also provide supervision and technical guidance to the local government disease surveillance and notification officers. The Federal Ministry of Health, like I said earlier, is responsible for coordinating the overall surveillance activities. The objectives of the measles surveillance system is to detect outbreaks early, to evaluate vaccination strategies, and to investigate the outbreaks. The objectives of performing the evaluation are to assess the system in terms of the system attributes, to assess whether the system is meeting its set objectives, and to identify gaps in the system. The study was conducted between December 2013 and March 2017, and it was done in Borno State, which is a state in northeastern Nigeria that is made up of 27 local governments and has a population of about 4.1 million. It is important to mention that Borno State has been recently plagued by terrorist-related activities. We conducted the evaluation using the CDC updated guidelines for surveillance systems as a guide, and we conducted it using quantitative methods where we interviewed 30 stakeholders from the the State Primary Healthcare Development Agency, as well as the local government disease surveillance and notification officers, we administered a structured questionnaire that was pre-tested to find out information about some of the attributes of the surveillance system. We also looked at data, surveillance data from 2013 to 2016. We got information that we used to calculate some rates, proportions, and then some of the attributes as well. We obtained permission to conduct this study from the Borno State Ministry of Health, and these are the results. The data quality was assessed using percentage of unknown or missing entries. We selected some variables from the data set we worked with, and using that, we were able to calculate the percentage of missing entries. And what we found was that 18% in total of entries only 18% had complete records in 2016, whereas 60.2 had complete records in 2015. For sensitivity, we found 2.5% in 2016 and 13.8% in 2015. For acceptability, 96% of the interviewed stakeholders were willing to continue to participate in the surveillance system. For stability, we found that the system is donor-driven. 68% of the interviewed stakeholders reported to have dedicated staff that collects, manage, and provide data. And 58% of the interviewed stakeholders reported that the system was interrupted at one point or the other due to insecurity. For representativeness, we found that data was generated from 24 out of the 27 local government areas, and it adequately described the occurrence of cases by person and place. For positive predictive value, we calculated 13.5% in 2016 and 48.5% in 2013. For flexibility, the electronic data formats are used to enter or collect, to record information, and we found that the system can accommodate modifications in data collection forms. And we also found that it is integrally linked to AFP surveillance system. Most of the human resources used in measles surveillance system are also involved in the AFP surveillance system. For simplicity, we found that 100% of the interviewed stakeholders agreed that the case definition was easy to apply and the surveillance tools were easy to fill. It involves multiple levels of reporting, and the cases that have been identified require laboratory confirmation. This is a table that shows some of the key measles surveillance indicators that were calculated. For the annualized detection of non-measles febrile rash, the target is greater than or equal to 2, and in all the years under review, the target was met. However, if we look at the proportion of suspected measles cases that are IgM positive, the target was not met in all the years under review. So it is based on these findings that we concluded that the measles surveillance system in Borno State is stable. It is simple to use as reported by the stakeholders. It is acceptable and representative, but it is complex because of the multiple levels of reporting and due to the laboratory component of it. However, the data quality, sensitivity, and predictive values were all low. Accordingly, we made recommendations that the State Ministry of Health should train surveillance officers on how to correctly collect and record data, and then periodic supervision of the disease surveillance and notification officers, which are the key principal officers in surveillance. Supervision of them is very important. The public health actions that we took, we conducted on-the-job training for the same surveillance officers on computer data entry. I also presented these findings at partner coordination meeting to disseminate to the state the information and bring to light the gaps that have been identified with an aim of improving the system. I would like to acknowledge the Borno State Ministry of Health, the African Network of Epidemiologists and Nigeria FELTIP, and then the WHO for assisting me to conduct this study. Thank you very much for listening. These are my references.
Thank you, Batula, for your presentation and having a willingness to share your experience with us. Now, floor is open for discussion, comments, questions, and everything else. Nada.
Thank you very much for the nice presentation. I have two questions. The first one, what do you collect as clinical specimen for your cases? Oral fluid, serum, urine, dried blood. So what kind of clinical specimens do you collect to confirm measles? And my second question is about sensitivity. What were your numerator and denominator to compute sensitivity, which was in your slide 2.5? Thank you.
Thank you very much for your question. To confirm the presence of measles, we collect blood specimens, which we send to the lab, and then it is separated. The serum is used to conduct serological tests to look for the immunoglobulin M or G. Thank you. The second question about sensitivity, it's the proportion of cases that are detected by the surveillance system. So it can also mean the ability to detect outbreaks or to monitor the disease occurrence over time. So we calculated sensitivity using the total number of people that are suspected to have the disease.
Other question? Thank you. Question? Yes, Sultan.
You mentioned that most cases occur during dry season. Any explanation for this?
Thank you, sir, for your question. From the literature, we know that measles is transmitted through respiratory droplets or aerosols. So during the dry season, it is very dry and windy, so it is possible that the aerosols can travel very far and affect a large group of people. So I think the dry season actually favors the transmission of the virus because of the easy aerosolization of the virus and then transmission.
Questions? Comments? Yes, Delphine.
Delphine Antoine, you mentioned when you were presenting stability indicator that the system is donor-driven, and I was wondering if you could explain a little bit more, because that has an impact, of course, on your stability of the system.
Thank you very much for the question. What I meant by saying the system is donor-driven is that most of the funding that comes for surveillance in measles comes from donors, and then just a little percentage comes from the Nigerian government. So it is donor-driven. So if a system is donor-driven, then it means anytime the donors withdraw, then the system is not likely to continue. Thank you.
Yes.
Thank you for your presentation. I want to ask about calculation of positive predictive value. What is the aim from calculating positive predictive value in syndromic surveillance?
Please take it again.
surveillance of measles is
Yes.
fever and rash surveillance. Yes, syndromic surveillance. Depend on fever and rash.
Yes.
Yes, so when we calculate the positive predictive value in syndromic surveillance, as the surveillance become better, positive predictive value will decrease because the system will catch a lot of negative cases. So what is the interpretation of the increase in positive predictive value from year to year? Thank you. Clear?
Thank you very much for your question. The positive predictive value is calculated because it is based on confirmation of cases that are reported through the surveillance system. So what it does is that it gives us, of the total percentage of people that are reported or suspected cases, how many of them are truly positive for measles. That's what the positive predictive value talks about. So I don't know if that answers your question. Because I didn't get you right.
Yeah. So, as the surveillance system is better, it will catch more negative cases. Yes?
Yes.
So, positive predictive value will decrease. Because the total positive predictive value is the number of positive cases by lab divided by the total number of cases caught by surveillance.
Yes.
Okay?
Yes.
This is what I
Yeah,
mean.
thank you.
Okay,
thank you for your comments.
Other comments, questions? No, thank you very much, Batula. Thank you very much.
Thank you.
Thank you, Fatima.